Welcome everyone to another CompuMed webinar. Today we are going to focus on the Slide Savvy series, as we like to call it, with Fernando. Many of you have either been on conference calls with Fernando or have you seen his previous webinar and this current one. Fernando, he's a lead pathologist assistant in the surgical pathology department at Rutgers and University Hospital in Newark, New Jersey. He has an incredible passion for teaching and educating and sharing his vast knowledge in slide preparation and how presenting really good slides will help with the better reads. So he's here to share some of his information. Today's focus is going to be on avoiding freeze artifacts in frozen slide sections. So Fernando, I'm just going to let you take it on.
Well, hello. Thank you so much, Laura, for having me again in this presentation. Well, thank you, everybody in the audience and all the team that was helping to make sure that we have everything that we need for this presentation. And to start the presentation. And I use this first slide because for freezing artifact, I think everybody is trying to see how we can actually avoid to have freezing artifact, but unfortunately, there's no way to avoid freezing artifact because freezing artifact is a product of interaction between everything that has water, in this case, human tissue, and the lower temperature that we are facing during the frozen section procedure, to the cryotomy procedure. So if we have water in this tissue, that obviously we will have freezing artifact. But what is this session about is exactly how to minimize the impact of freezing artifact in the tissue. So our pathologist can have a better view of the architecture and understanding to render a proper diagnosis. This slide is talking about water content by organ. And although as a reference, I have, for instance, teeth there that is 5%, we can see that the difference between different organs in the body. And this difference, it also can translate it to the field of our surgical pathology examination, in this case, the frozen section procedure. And you can see how the tissue changes. Like, for instance, adipose tissue going to the other side, it has 23% of fat, which makes us less prone to have this freezing artifact. But also, we know that fat freezes minus 80 and so on, and less. So we have different amounts of water in the field that we are basically in the realm of the OPOs. We have tissue transplantation for liver. We have lung, we have kidneys. And you can see the water content in liver is approximately 71%. Now, this is healthy individuals that probably don't have any problems. These measurements were taken from making a calculation with bodies that were weighted, and then the organs were isolated, and many variables about the presence of disease, but more or less these percentages remain the same. And this is important to know, and this is important to remember when we're going to go through the cases. Okay? So we have certain things that we need to observe when we're cutting frozen sections, and I always stress this because it has to be in stone. Actually, that is minus 24. Cryostat temperature should be minus 24 degrees. And why is this important? Because what we have in the cryostat setup as minus 24, the real temperature that we're going to have in the area of the stage will be around 17, minus 17, minus 18. Having set up this temperature, it will prevent two ice formation and will help us. And if we have this process standardized, we're all going to be facing more or less the same exact temperature. And if we introduce a variable completely different, which is in this case will be a different type of tissue, let's say kidney, which obviously filters blood and water, and blood has water. So we'll be knowing that our standard temperature is something that we had set up in the cryoset of the OPOs, and then facing this type of tissue, which is the kidney tissue, will make us to make the difference when we are facing, for instance, liver tissue, which has a little bit less water content. But the variable that is the temperature remains the same, and that's important to keep. The sections also are 5 microns and should be at 5 microns because if we have over 6 or 7 microns, it's going to be a superposition of layers of cells. And we go to less than 5 microns, desiccation, for instance, and the section will be so thin that by the time we have that on the slide, it will introduce something called drying artifact as well. So 5 microns, top 6 microns will be acceptable for that. The temperature of the tissue, like I mentioned before, on the chalk, in the area where the tissue is -17, -18. Other important thing is to have preventive maintenance done in all our equipment. And last is using that we were using for so many years, the Dr. Peters cryo embedding system, which also help us to achieve not only temperature, but perfectly embedding the tissue flat. So every surface will be face the blade at the same level. And all of this is important to know again when we go into the last slide. Now we have different types of artifacts. And hopefully in the following series of talking with you guys, we're gonna talk about this like thermal artifact, crushing artifact, shattering, the Venetian blind effect, the butter effect on sections that are like fatty or have or are not at the right temperature, the drying artifact, the staining artifact, and something I found lately about that, the covered sleeping artifact that also can have a huge impact on interpreting the slides. But in this case, we're gonna focus on freezing artifact. So how we can identify freezing artifact? And there are subtypes of freezing artifact. Like in this slide, we can see, you see these spaces between the layers of tissue, and you can see these little small holes and big holes. Now the cells of the layering are quite intact a little bit, but you can see these spaces like simulate bubbles. Our trained pathologists obviously are gonna determine that this is not fatty tissue because fat actually looks like in this way. The translucency of fat and the light microscopy and H&E staining looks in this way. But actually for the trained eye, our pathologists will determine that this actually is the bubble type freezing artifact. It was a lot of water content, and all of a sudden everything is freeze and compress the tissue around and leaves when we're going through the different stainings and washings from water to alcohols, then we leave these spaces and create this appearance of fatty tissue when it's really not fatty tissue, like we're gonna see in the cases. Then we have, this is more frequent, and this is something that we see more about the compression artifact. To the right of the slides, we can see the permanent section, and we can see the outline of the cells. We see the cell membranes. We see the tubuli. Those are renal tubuli. We can see the spaces, the lumen, well preserved. But in the left side of the slide, you can see how these tubules are being compressed and how they are being squeezed on the walls, and how this architecture, and this actually being exactly the same tissue. It's just that the tissue on the left is, well, we were cutting the frozen section, and the tissue on the right is the same tissue exposed to the lower temperature, but overnight process. So we can see these crushing areas on the tubules. And if we compare this, the architecture here, you can see the epithelium of this tubuli perfectly preserved to the extent of using a tissue that was obviously previously exposed to freezing, but still you can see the contours and you can see the architecture preserved. And in this case, you see the compression of everything around, the interstitium and the tubuli. So this tubuli was compressed to the center and basically kind of imploded in the center, leaving this space around. And this is one of the most frequent types of freezing artifact that we have, is called compression artifact. Then we have and this type of chromatin changes. This is more fine, really looking, and this is obviously for our pathologist to determine about these chromatin changes because we're examining the nucleoli here. But you can see into the left is the frozen section original. And you can see to the right exactly how the permanent look like all the way to the right. That's the permanent, and then left is the tissue with chromatin changes. And you can see how this, these are two examples of different tissue to the right, but you can see how the chromatin actually changes when it's exposed to that. You can see fragmentation also the cells into the left, the cytoplasm of the cells into the left. And a little bit of this bubble of vacuolization as well into the left that we don't see into the right. And another type of freezing artifact also is nuclear holes. And we're going to see actually in one of these slides that we have for practice how the tissue architecture actually, it looks good and the pathologists were able to make a diagnosis. But like I said in the first slide, it's impossible to avoid freezing artifacts. Sometimes it's just not possible because of the nature of the tissue. But it won't prevent us to actually make render a good diagnosis, but it still is going to be there. You can see the same tissue on the right after the permanent section was processed overnight, and you can see to the left that there is no vacuolization. And now we're going to this part that we have 6 cases, actually 7 cases that we're going to evaluate. Okay, thank you. So this is an example of this global, really, not talking about the staining. The staining looks as good. I don't see any other problems with this slide, but when you zoom in and when you try to evaluate actually the morphology of this, you can see how extensive the freezing artifact, in this case, will be compression artifact. You can see how the cells are being compressed and basically form like cords all over the place, and you cannot really see that. There is steatosis, yes, for sure, but we also can see some bubbling here as well. But I want you to focus basically how it looks like in this type of freezing artifact, which is the compression artifact on a liver case. This is a liver biopsy. You can see the cords of tissue, how it's being compressed. It looks like interstitium, but it's actually the cells that are being compressed to the tissue, and the tissue is being pushed to each other and forming this cord-like appearance. Now, if you see that, you know, from bigger view, you can see the staining is quite good. The staining is not bad. The cord is completely effaced, and you can see the cord, basically the entire core, which is also good. But again, the freezing artifact in this case is the one that completely is unreadable. Now I have a second case here. And the staining here is a problem, but you can see areas where more or less you can see a little preserved the structure, but you can see a lot of bubbling here. And obviously this bubbling also goes with less staining. And that's the reason why I choose that. So this is not actually a steatosis. This is actually freezing artifact, the bubble type freezing artifact happening in these areas. In comparison to this other one that's less than that, and this one's a little hemosiderin probably around, but you can observe in this area a lot of this bubbling effect. Okay, I'm gonna go to the next one. Staining, really good. We had triads, we have a lot, but we need, and the reason I choose this one is because it has also, you can see closer and approach that. You can see the nuclear. I don't know if you can see that. Yes, right here, you can see the nuclei with little holes. And this is the type of nuclear vacuolization that we have, so it's a freezing artifact. Now, did this prevent this pathologist to read? We can see a little also compression artifact around. There's not much, but you can see that. Here, the tissue is more uniform without compression artifact, but you can see that it's around. But if you zoom in more, you can see a lot of this vacuolization of the nuclei. which is also part of the freezing artifact. I have another one here. And in this case, there's a little bit of pixelation, but I mean, most people who are pathology will say, okay, this looks like even like it's necrotic, but it's not. It's a combination of freezing artifact, vacuolization, compression a lot, and bubble as well. And all of that actually ended having a poor staining on the section, making this basically unreadable. Now for the other two, is 3 slides I have. And now this is a kidney. Okay, it's a good wedge, actually. It's a nice wedge. We have a lot of shattering as well here. And when we zoom in, the staining is a little bit intense too because of the thickness. Can actually talk about a little bit about that and a differentiation when we talk about the thickness and how the thickness of the section actually, a lot of people say is overstain, but it's not overstain, it's actually thick. It's past the 5 microns. Remember when we mentioned that it has to be standardized at 5 microns. Okay, so with the temperature in this case, and the section was not, perhaps the cryostat was not set at 5 microns, so it gives you a thicker section, or when we go through the stainer, the staining is a little more intense, and it might be rendered as high, like overstain, but it's really the thickness, the problem here. Besides that, we can see a lot of crushing artifact here. Freezing artifact, the crushing type here, how these tubules, all of these were tubules in these areas over here. Now we can see some intact, or at least not that compromised in these areas, but we can see the compression here all over the place. It's all compressed. And the shattering. Let's see if we can find an area where there's not that. And the tubuli are more reserved. Sorry if I go too fast, sometimes I do that. But it's a little bit less compressed, but look, here is all compressed in these areas right here. These tubular efforts, all compressed, is like an implosion in this area. So make this obviously one of the pathologists had to evaluate the glomeruli, the interstitium. In this case, the interstitium will be like similar basically to the tubuli, which is other things, and they're going to evaluate the blood vessels as well, and everything. And this globally, the architecture changed because the freezing artifact. Let's go to the next one. And we have another for biopsy with a lot of compression artifact. See, it forms like cords all over. And make this obviously completely useless, unreadable. So issues in this case are the freezing artifact. We can see some bubbles around, but it's not really preventing from reading. But the crushing is very notorious. Let's see, we can see some vacuolization. I'm seeing this one much, but the architecture is completely changed in this core liver biopsy as well. Navigate to the other end of the core. And it's just compression all over the place in bubble effect as well.
Hey, Fernando, I'm gonna, you got a really good question. Thought if you don't mind, we'll jump in on that one.
No.
Great. So this is from Corey. He says, we normally cut our frozens at 4 microns. When it comes to too thick slides, what are some common causes? Not having an even face with the cutting slide?
Okay, so you're cutting at 4. Our suggestion will be 5, because with 4 and less, I've seen a lot of places that actually had this protocol cutting at 3 actually. for kidney, because kidney cores sometimes and the small cores are really flimsy, and sometimes they are not flat embedded, and then you start going through the tissue, and then you ended not having too much tissue at the end. And if the core, for instance, was embedded in a fashion that the first part of the core is going to go, and then all of a sudden you're going to start exhausting the tissue too much, and you're just going to have a little portion at the end. That's why we're using the Dr. Peters cryo-embedding system, because it is going to make sure that it's even the cores, the small tiny cores, will be completely flat. And when you efface, the effacing is completely even. But let's say you cut it at 4 microns. We're facing another problem, which is desiccation. And desiccation is important because it's going to affect your staining as well. So that's why we standardize this at 5 microns as the middle point. Not going too thin as well, and not going too thick, because the superposition of cells at 6 or 7 microns is just not good to isolate these layers of cells, and they will be superposed to each other. And yes, you're probably going to look better isolation of cells at 4 microns, but you're also going to face the desiccation. And if in some areas, some labs that we visited, actually, they don't have a quick fixation of the light. When you obtain the slide, in some labs, actually, that goes straight to the staining, or just leave it dry. And that's not a good practice either. And I don't know exactly the procedures they're going to follow in your lab, but immediately after you pick up the section, you have the section on the negatively charged light. It's very important to have that. Then you dip that and fix it. This will prevent for the sample to desiccate, and also will actually help the staining when it goes into the stainer. So that's why we suggest the 5 microns as the gold standard. And if we follow that 5 microns and something else is going on, then we need to find out exactly it was the stainer, the solutions, the fixation before staining, or maybe it took too long for the person actually to pick up the section on the slide, which is also extremely important. This is a process that involves muscle memory, but it has to be immediate. Like when you have the slide, in the section on the stage, immediately has to be picked up. If you take a little longer, or you start going to cut and it takes 2, 3, 4 more seconds, the staining, the quality of the staining and the thickness is not going to be even. I hope that answered your question.
Actually, we have another question too. So, because I think this leads to some other dialogue too. Is freezing artifact more prevalent on needle biopsies or wedge?
Yes, definitely needle biopsies, and it's because it's related to the volume of tissue and how fast this tissue freezes, and also the water content. The changes of temperature also are going to be important on the thickness of tissue and the volume of tissue. So to have freezing artifact, like we can see, are more prone to have in core biopsies are more prone to have a freezing artifact. But again, it's not completely in stone. It's because we can see this. This is our wedge, and it's all over. And the tissue was supposed to be well preserved, but in this case, they let this tissue to sit too much, and it's really extremely cold. And the tissue at the time of freezing, it took a little longer to freeze. That's the first part. It was created already, and the tissue, the freezing artifact, the compression artifact in this case, and then it was left too long before cutting, and that's what created this shattering. So there's these 2 components happening here at the same time, and in different times and different parts of the procedure that ended to having this result. But I will say in global in general, cores are more prone to have this freezing artifact than actually wedges. In this case, I don't know if that answered the question. If we have anybody else before we move to the next slide.
But why don't we keep going? I think you had some other slides, so thank you.
Yes, no
More
problem.
questions
Absolutely.
too.
Okay.
Thanks.
And I have this as a wedge biopsy, and you can see there are 2 problems here. The first, this was reported as a pathologist as overstain. And again, we have the knowledge that this is not actually overstaining, because most of the stainers, and good thing, so many places like SDA actually, they have this automatic stainer. So the staining time on each solution is automated now. So we have that standardized. So we cannot blame on the operator, leaving the tissue or air drying or something. It's happening at the same time. It's a standard. But what happened here is that this section is too thick. And because of the thickness, it gives us this impression of overstaining, but really it's not. And you can see how busy they look like because it's superposition of cells, and that's why happened. And this most likely is because it was cut too hot. It was not cold enough. It was not cold enough, and you can see that. And we can see the compression artifact all over the place as well. And that's why I choose that because the compression artifact you can see here, the tubuli, all these are tubuli, and all with compression artifact. You can even see the epithelium here. You can see the lumen, but no epithelium at all. So it's one less parameter for our pathologists to read this section. And it's so busy because it's superposition, not a lot, but it's not the right thickness. Ergo, it took more stain and it looks more pycnotic in this case. Okay, and then this will be the last case for the freezing artifact, and we're gonna go back. And now we're gonna talk a little bit about how we can minimize the freezing artifact. Because like I said before in the first, it's water there. It's impossible to avoid that, but we can minimize that. And one of the things that through the years actually helped me to understand the process, working along with Dr. Peters, it was that if you don't have appropriate training and practice, definitely you won't be identifying when you're going to have the freeze. So you can actually prevent this from happening. And when you're cutting a section, you actually know, okay, so this is not going to end good. So this includes the practice. A practice is something that I will help you to understand. So you have the part of what we went through a little bit, at least, is the concepts of why this is happening, right? This is the conceptual part of that. But when you translate that into actually, when you are in front of the cryostat, you need all this knowledge and the appropriate training to avoid that. Why? Because this cutting of frozen section is muscle memory, part of muscle memory, but also you need to start putting the dots together. You know, what kind of tissue I received? Like, thank you for that question. Is this a core biopsy or this is a wedge biopsy? Now, are we facing, this is a liver core or this is a kidney wedge? So just from the very beginning of knowing what kind of tissue we're facing, we can say, okay, the water content of this tissue is going to be maybe a little more than normal. It was received on this preserved solution that helped to preserve the cells, or it was received in saline, or it was received dry. That also will have an impact on how we're going to train, because again, it goes to the water content, and it was receiving some transport media, the water content will be a lot. So it's good to have a way to, without crushing the tissue, without, not handling well the tissue, to try to dry, to try to minimize using a gauze, for example, can actually help us to reduce the amount of water that came with the tissue because of the transport media that they use. So these are part of the training. And the next part will be, okay, so we will have a wedge. How are we going to embed this wedge? Are we going to use a small bar, or we're going to use a big well bar? Because it's going to give you room for more OCT around that, and it will be a better handling for the tissue as well. So there's part of the training as well. Like I say, identifying the nature of the tissue, coarse versus wedge, is important. And one of the questions actually that popped before the seminar was about the OCT. And thank you for that question, because it's really important. We, at the beginning, this is back in 2010, we didn't have that because our refrigerators actually were in the histology area, which was a little far from us. But now we have one refrigerator on hand right next to us, so we can pre-chill the OCT. Now, most of these fridges are between 2 to 6 to 8 degrees. So having this OCT pre-chill storage in that, it will help us a lot. I don't advise really to have it in the cryostat, because sometimes you know when the tissue is coming, or you expect the tissue, but sometimes it takes longer. So you won't be in control of the OCT. if you keep it in the cryostat just to chill out. It's better to have it in a controlled environment, which is a fridge that we will, we have charts and it's well controlled, and it's between 4 to 6 degrees. Then the well bars and chucks and the heat extractors should be at the bottom of the cryostat. This is extremely important because they will keep that to very low temperatures, and this will help to obtain appropriate temperature when we are embedding. So keep always these chucks, heat extractors, line up and at the bottom was cryostat. And sometimes some cryostat actually have these special areas where there is the lowest temperature area, and these bars or flat structures that are made for that. Like this is the lowest area where you know that the lowest temperature is in that area. And this is important because we have to rapidly freeze the sample. The longer we take, the more this crushing artifact or freezing artifact, crashing looking artifact, it will appear in the section. So that's why it's important to have all these heat extractors, the chucks, right? And the well bars in this area where this is the coldest area. And the last thing I want to talk is about the good practices actually on what I call the TIC-RM. It's really CRM. This is something this is called crude resource management, but in my setting, with residents coming every year, with always somebody to train about fronts and sections and stuff, it's good to know that we need to have hardware in place, well maintained, and with temperatures well controlled. Then we need to have the right tools as well for doing this. The staining, I suggest to have automatic staining. It's really, really good. It's one more thing that we have standardized. Then follow these recommendations. Again, those are recommendations about the temperature, the cryostat, the recommendations in the temperatures, in the way we fix this tissue before we implement this with STA and I believe with the sharing network as well in New Jersey. And the most important part is actually have this resource management with the training. Appropriate training will make sure that the lead and the team will always identify what's going on. Is this, because for freezing, having this freezing artifact is not only one reason or one variable. It sometimes is not only the temperature that we're cutting, but also how to identify if the sample actually is too cold or is too hot, to avoid, well, in this case will be too hot, too cold. How do we identify that? And this process is knowing and hearing when the blade actually meets the tissue and how crunchy it is. So that's something that only comes with practice. So immediately you're cutting the section, say, stop right there. This is too cold, and we need to kind of apply the palm of our hands or maybe the thumb and kind of lower the temperature, because this is not only going to chatter, but it also will have freezing artifact. And this is something that also happens with observation. When we obtain a sample, a section, and if people who cut frozen sections are listening to me, that when it starts curling from the top, if you see that the section start curling from the top, it's too cold. We need to immediately apply the palm of our hands for 1 or 2 seconds, not too long, but that will be good enough for the section to level. Then we need to cut a few sections to make sure that this 5 microns is, again, a mechanical 5 microns. And then we can obtain sections. And you'll see the difference. Immediately, you'll see the difference. But those observation, this observation only comes with practice. So when it's curling, okay, too cold. You hear that when you're cutting, it's too much resistance on the blade, it's too cold. And then for sure that section will have freezing artifact.
We had a couple questions, Fernando, yes. If you have a minute. Can we jump in?
Yes.
So what sort of time, seconds, apparently, mostly, should the freezing process take to minimize the freezing artifact? Is there like a measure?
Usually, we'll say, yes, Dr. Peters mentioned that sometimes it's between 25 or 30 seconds to depending on the section and depending on the well. We have like the 30 millimeter well, and then we have the 20 millimeter and the 10 millimeter well. And each well actually has a different setup of temperatures for that to happen. But if you use the standard 20 millimeter wells, it could be between 15 to 20 seconds to have that. And again, if you start effacing the chuck, and let's say because your cryostat, even though you have it at -24, and you see that you start cutting, and the first section where you're facing the block, it becomes too soft, then it's just an observational thing that comes with practice. You might have a timer next to you, and then you might help to do, okay, so 15, 20 seconds. After that, I will have the right temperature. But sometimes depending on the setup of the main cryostat, because if it's not 24 or 25, you have it different setup, then this more or less time will be changed as well.
Okay. This next is a kind of a bunch of little questions together. So what type of method should we use to transport the biopsy material from the OR to the lab? And what solution should we store it in, and should we pat it dry?
Okay, so living tissues that are out of exsanguinated, and they have the blood supply is cut, right? So it's ischemia. It's ischemic time on the tissue already. When the tissue abandons the body, is biopsy, it's excised from the body, there is ischemia. And this ischemic time, there is no circulation on the tissue. Obviously, at the cellular level, we're gonna start having that the sample is gonna shrink a little bit, but also desiccation is gonna happen. It's gonna appear desiccation on the tissue. So if we have a transfer in a dry material, dry telfa pad or dry gauze, this will be causing issues, not only taking the tissue out of that, because that, we're going to break the whole tissue. We're going to destroy the tissue trying to obtain the tissue, because immediately, as soon as the tissue is in contact with these dry surfaces, immediately it's going to create a bond. And this bond will prevent us to take the tissue out and will break the tissue. So that's one thing. And the other thing, again, is the desiccation between the exposure of the temperature. And it will start desiccation, extracting water, dehydrating the tissue. So by the time we have it in our table on the grossing area and on the cryostat will be dry. And that will introduce a different type of artifact. So how we can prevent that? Well, saline, but not be the tissue not be immersed in saline. What we can do is actually have a telfa pad. And people with you know there's a telfa pad. It's a type of gauze, but it has a film on top. And this film has little minute holes that actually make this liquid to go in, but not going out. So this actually will make sure it will help the tissue to have to be moist at the time we receive the tissue, but not completely soaking water or soaking in saline, which also introduce more water to something that we're trying to control. So tissue that is on a telfa pad that is moist in saline will be ideal for receiving
Okay.
MBR on our surgical area. Yes.
Right. Thank you so much. So I think that's all the questions we have. So I'm gonna just let you go ahead and wrap up at this point. I think go back to your credits, because I think that's really near and dear to your heart, Dr. Peterson. So.
Oh, yes. I use the Dr. Peters process section technique book.
Yeah.
It's something that is for whoever is out there and really want to go in depth about this. Remember, we were training now pathologists. Many of them are directors in many things, and many, But at that time, when these young physicians come to our lab, they start experimenting in things, and really this book is related to that practice, because training physicians, training future pathologists was made in this case, but also has some interesting technical facts about everything that is related to frozen section. So I will advise guys to really take a look at this, and we can discuss this together as well. With Dr. Peters, we were working really hard to make sure the residents interpret this book and the different chapters in the way they should be. So it's a very good tool to have. And then obviously the really good and vast CompuMed database that help us to isolate these cases and present them to you. Thank you.
So great. We really, really appreciate, Fernando, your time, and especially your time up front, putting this together. So, you know, the 30 to 40 minutes, as we know, always takes a little bit more time than this is here. And we really appreciate everyone who participated today. Please, if you have questions on this, on any of our other services, how we can help your labs with pathology, with the slide prep, procedures and process. Fernando actually works with CompuMed, going on site with our OPO customers. So we really look forward to hearing from all of you, and we will continue to have more of these. And, you know, CompuMed's goal is to really help all of the OPOs in your donor management, and with the same goal that you have to help, you know, have more organs to save more lives with the donor, with the recipients. So thank you again for trusting us.
Thank you, everybody. Thank you to the team as well. Thanks. Pleasure.